welcomes all the participants for today's Regional Distance Learning Seminar Series. We are starting with the dissemination of the national guidelines for HIV care and treatment through the RDLS sessions. The first topic is diagnosis of HIV infection in adults and children and assessment of adults and adolescents with HIV infection. Today's speaker is Dr. S. Anuradha, Madam. Dr. S. Anuradha is the Director, Professor of Medicine and the Nodal Officer at the ART Center, as well as the Program Director of the COE in HIV at the Maulana Azad Medical College, New Delhi. She has done her Masters in Infectious Diseases from the London School of Hygiene and Tropical Medicine, University of London. She is the recipient of the Fogarty Fellowship in HIV Medicine, UCLA. She is also the member of the Technical Resource Group ART and R&D at the National AIDS Control Organization. We welcome you, ma'am, for today's session. Just an announcement before I hand over to ma'am. Please fill in the pre-test questionnaire. The link has been sent in email as well as it has been pasted in the chat box. Thank you. Ma'am, over to you, please.
Good afternoon, everybody. Welcome to today's RDLS, and we are going to start with a very important session today as to how we are going to diagnose HIV infection in adults and children, and how we are going to assess adults and adolescents who present with HIV infection to our ART center. Next, please. So when we talk about the diagnosis of HIV infection, it is very important to remember that it is very, very vital to diagnose HIV infection as soon as we suspect it, or at any point of time when the person comes in contact with the healthcare system. It is important to diagnose HIV early because the late diagnosis of HIV is an important factor that is associated with HIV-related morbidity and mortality. So the longer the HIV virus has been in the system undiagnosed, the more likely you are likely to encounter both morbidity related to the HIV as well as it contributes to long-term mortality in these patients. One should always encourage voluntary HIV testing after informed consent. It should be offered and encouraged at any point of time any person comes in contact with the healthcare system, so that we are able to diagnose more and more patients with HIV infections. HIV infection in any individual above 18 months of age can be done or can be detected by the laboratory tests that demonstrate either the virus or the viral products or antibodies to the virus in the blood, serum, or plasma. It is important to note that especially antibodies less than 18 months of age are not important or not adequate enough to diagnose HIV in children less than 18 months, because if the mother is HIV positive, maternal antibodies may persist in the child's plasma, and the diagnosis in children below the age of 18 months is always made by qualitative PCR reaction or polymerase chain reaction tests that detect the HIV nucleic acid. And once beyond 18 months, then you confirm it again with the antibody test to the HIV virus. Next. So if you look at the diagnosis of HIV under the National AIDS Control Program, the diagnosis is based on rapid tests that are based on the principles of enzyme immunoassay, immunochromatography, that is lateral flow assays, immunoconcentration or dot blot assays, vertical flow, and particle agglutination. So these are all the various kinds of rapid tests that are used as part of our HIV diagnosis in the program. All these different rapid tests should have a sensitivity of more than equal to 99.5% and a specificity of more than equal to 98%. That means if they have a sensitivity, if they are highly sensitive tests, they will pick up all positive persons. And if they are very highly specific, they will not pick up the negative persons. So you will have very low false positive and false negative rates. It is also very important to remember the concept of what is called the window period. The window period represents the time period. It's a period of time between when a person becomes infected with HIV infection and the time by which HIV antibodies can be detected in that person's blood, which takes about 6 to 12 weeks and an average about 8 to 12 weeks. If during this window period, a blood test is performed on the patient to detect HIV using antibody-based tests, Since antibodies have not yet been formed in the person, the test is likely to yield a negative result. So, in case you feel that the person may be in the window period, you may require and you will require further testing after 12 additional weeks, so that then you can confirm whether or not HIV is present or not present. And so it is very important to remember the concept of window period when we talk about HIV testing in our program, because in our program, HIV testing is largely based on antibody-based tests in adults and adolescents, except for in children where we use PCR-based technology. Next. So if you look at the diagnosis of HIV in adults and children more than 18 months of age, in view of the overall low prevalence, because India comes under a low prevalence of HIV, it is necessary to use 3 different principles or antigen-based rapid tests to confirm the diagnosis. So it is not adequate enough to give a positive report on the basis of one test. All the samples, so when we do 3 tests, they are done sequentially. So all the samples that are reactive in the first test, that is, if the first test is positive or reactive, they should undergo further confirmatory tests with the second and a third test, which are based on different principles or antigens. But remember, it is the same sample of serum of the patient which is used to find out antibodies for all the 3 tests. You don't use 3 different samples. It is the same sample of the patient of the serum which is used for all the 3 tests. So your first test report has to be positive. Then you will subsequently perform a second and a third test. And like I said, the same blood sample is utilized for performing all the 3 tests for identifying HIV antibodies. Sometimes if you get what is called an indeterminate result, or the test is not very clearly positive or negative, all such patients should have a repeat sampling and a repeat testing done on a second sample of blood, which should be taken after a period of 14 to 28 days. So the patient must undergo a repeat test in case an indeterminate result is obtained on the first test of the patient. Next. So let us look at the strategy for the diagnosis of HIV in patients or in people who are clinically asymptomatic. So these are people who have been sent for testing but are clinically asymptomatic individuals. So first we perform the first assay or the first test. Let us look at what happens and how we go beyond that. If the first test is positive, then you go further down the algorithm. However, if the first test is negative, we report that patient or that test as negative and end the cascade there. So the patient gets reported as negative if the first test is negative. If the first test is positive, then you perform the second assay. And then depending upon whether or not the second test is also positive or negative, you perform the third test, which is the A3 or the third analysis. Now, there can be different scenarios depending upon what is happening to the combination of these tests. If all 3 assays, A1, A2, and A3 are positive, the interpretation of this report is that the patient has tested positive. You perform a post-test counseling and then link the patient for HIV services. If the person has the first test positive and either the second or the third test negative, meaning out of the 3, 2 are positive and 1 is negative, it is reported as an indeterminate test. And like I said, this person would have to undergo a second test after 14 to 28 days. Suppose the sample is positive for the first test, but the second and the third tests are negative, then one should consider indeterminate, high risk or low risk, depending upon what is the risk. If the person is high risk behavior, like person comes from a key population, then it can be interpreted as an indeterminate test, which means the person would have a further testing after 14 to 28 days. However, if the person is of low risk, then you can consider reporting it as a negative test and no further testing is required. But of course, this risk categorization has to be done very carefully before you label the person as negative. all indeterminate results have to undergo a second testing after 14 to 28 days. Next, please. So now let us now look at the diagnosis of HIV infection in infants and children who are less than 18 months of age. Like I said, maternal antibodies to HIV usually persist for nearly 9 to 12, sometimes even up to 18 months in the infant. So the presence of merely detection of antibodies in a child who is less than 18 months of age does not confirm HIV infection. And so children born to HIV infected mothers will often test positive for HIV antibodies, regardless of whether or not they themselves are infected, and they will just reflect the mother's positive status. So NACO always recommends the use of total nucleic acid, a TNA PCR tests, performed on a dried blood spot or a DBS sample of the infant to detect viral nucleic acids for the diagnosis of HIV-1 infection during infancy. This test is performed at 6 weeks of age or at the earliest opportunity when the infant comes in contact with the healthcare system. Remember, many of our vaccination programs start when the infant comes at 6 weeks of age to the healthcare system. And so that is the first window of opportunity where you can perform the test. However, if the child or the infant presents earlier than that and you do have an opportunity to test it, then you can do it earlier than that also. But at least at 6 weeks of age, the first DBS for PCR must be performed. At and after 6 months of age, the TNA PCR must be performed after screening for HIV antibodies. Breastfeeding children are tested again 3 months after complete cessation of breastfeeding or 18 months of age, whichever is later. Remember, sometimes mothers may continue to breastfeed their children late into their infancy. So even at the age of 13, 14, 15 months, the child may be breastfeeding. So in that situation, 3 months after the child has completely stopped breastfeeding, or 18 months, the child attains 18 months, whichever is later or longer. At that point of time, the child is retested for the HIV infection. Next, please. So this is just a slide that shows you what is the classification of HIV and what are the different types of HIV viruses that are known. So HIV is predominantly of two types, HIV-1 virus and HIV-2 viruses. HIV-1 virus is further divided into three major subtypes, clades M, N, and O. And M for major, N for new, O for outlier. And the M is further divided into multiple subtypes A to K, excluding the one predominant subtype, excluding one. The predominant subtype in India is H1MC. This is how you will write HIV-1 M major clade C, subtype C. This is how you will write when you write the virus. It is important to know this epidemiologically so that when we try to find out the linkages and the genetics of the virus and how the virus has been transmitted over generations, it helps to establish that kind of a linkage. HIV-2 virus has 5 subtypes A to E. And it is important to know that most of the HIV infection worldwide is HIV-1, though HIV-2 infection alone or in combination with HIV-1 infection is also known in certain subparts, in certain pockets of Africa, and also in some areas in India also. There is a slightly higher incidence of HIV-2 infections that has been reported. It is important to know whether the patient is infected with HIV-1 or HIV-2 viruses because the treatment differs slightly. Also, HIV-2 is not amenable to the earlier used regimens of NNRTI-based regimens. HIV-2 progresses slightly slower than HIV-1 virus. There is no viral load estimation available for HIV-2 virus. So all the tests which are done for serial monitoring of these patients are solely CD4 based and they do not have any viral load for either detection or confirmation of failure of regimen. So it is important to note whether the patient has HIV-1, HIV-2, or co-infection with HIV-1 and HIV-2. And when we perform our tests for diagnosis, our reports always tell us whether it is HIV-1 or HIV-2 or a co-infection that we are dealing with. Next, please. Sometimes patients come to us with HIV-2 diagnosis, which requires a confirmation. The ICTC may give us a report which says either HIV-2 HIV-2 infection or HIV-1 HIV-2 co-infection. Anybody who has such a report with the from the ICTC should be referred to the nearest ART center, like all other patients who are detected to have HIV infection should be. The ART center should access and assess that ICTC report and see whether the patient is found to be only HIV-2 reactive by 2 tests, or the patient is found to have HIV-1 and HIV-2 both co-infection at the ICTC, or only one test has been done and only one report has reported it as HIV-2 positive from the ICTC. If the ICTC has been able to demonstrate HIV-2 reactivity by 2 differentiating testing kits, then it's reported as HIV-2 and no further testing is required for this patient, and the patient is labeled as having HIV-2 infection. However, anybody who has HIV-1, HIV-2 co-infection, or is diagnosed or is detected to have only one HIV-2 reactive test report, both these should be confirmed from the HIV-2 referral laboratory to which the ART center is linked. And there are well-established linkages which all of you must be familiar with as to which is your nearby referral laboratory where you would send the sample of the patient for confirmation of the HIV-2 test result. Next, please. So this is a flow chart that shows how one should refer these patients to the HIV testing referral laboratory from the ART center. So anybody who has this, who is indicated for a repeat testing to an referral, the ART center sends the patient to the designated HIV testing laboratory along with a completely filled referral slip. There at the laboratory, a fresh blood specimen is collected. So you don't send the blood sample from the ART center. The person has to go to the ART referral center, to the reference laboratory, where at the lab itself, a fresh sample for blood is drawn and a fresh blood specimen is collected there. There are, as per the national algorithm for HIV-2 serodiagnosis, which is available at the referral centers, they test these patients' bloods, and the test report is sent to the ART center both by email as well as by hard copy. And when the patient goes over to collect the report, you can hand over the original report to the patient while retaining a copy at the ART center. So this is the kind of a flow chart which is there for patients for testing for HIV-2 at the referral laboratory or the reference laboratory in case of HIV-2 positivity that requires confirmation. Next, please. Let us now come to the next part of the session, which is how are we going to assess adults and adolescents who present with HIV infection. Once a person is detected to be HIV infected and comes with a positive report from the ICTC, that person has to undergo a clinical assessment, certain laboratory assessments, and certain other biochemical and immunological assessments at the first presentation. And this session, or this part of the session, will tell us what are all the assessments that have to be done for these patients and how do we go about assessing these adults and adolescents with HIV infection. This session does not include children. There is a separate session on assessment of the child with HIV infection, and so we will be restricting ourselves to adolescents and adults. Next, please. So in initial evaluation of any person living with HIV infection, there are 3 basic steps. The first step is clinical assessment and taking of a detailed medical history. The second step involves a detailed physical examination or a physical assessment of the patient. And the third step are certain baseline laboratory evaluations and certain laboratory assessments that you would perform in all PLHIV at the first visit to the ART center. Next. So the first step in clinical assessment of any patient would be history taking. And this is true for any person who presents to any part of the health system. It's like doing our first examination, assessment, clinical evaluation, which is to take a detailed medical history. What we are able to do after doing this assessment and taking a medical history is, we first determine the clinical stage of HIV infection. There may be certain indicators in the history that may identify the clinical stage of HIV infection. For example, if a patient says that a patient has oral ulcers and after detailed examination you find that there is oral candida which is present, then that puts the patient in clinical stage 3. If the patient is currently undergoing treatment for tuberculosis, if it is pulmonary TB, it becomes stage 3. If it is extrapulmonary TB, the patient is classified as stage 4. So, with the history and examination, we are able to determine the clinical stage of HIV infection, which is very important for us to know at baseline that what was the clinical stage of HIV infection. We can also identify what are the current ongoing HIV-related illnesses that might require treatment. So in addition to the HIV infection per se, there may be multiple other illnesses or other manifestations of HIV that might require management. And so we are able to identify those after doing a detailed history and a clinical examination. It is very important to take a detailed history of antiretroviral drug exposure in the past. Many times, although the patient may be presenting to this ART center for the first time, the patient could have been in contact with the health system in the private setup, in any other ART center in the past, could have taken ARVs in the past, taken, then stopped, could have interrupted treatment. A woman who was pregnant in a prior pregnancy may have been given a single dose of nevirapine at that time. So it is very important to specifically ask patients, is this the first time that you are presenting to any ART center or any doctor with a diagnosis of HIV, and have you ever received any antiretroviral treatment in any form before? It is very important to know that, because prior ARV exposure can change the outcome of the ARV regimen that you prescribe to patients. On the basis of the history and examination, we can also determine the need for OI prophylaxis. For example, if there is a documented history that patient has had cryptococcal meningitis in the past, then you know that patient has to be put on secondary prophylaxis for cryptococcal meningitis. So the determination of the need for OI prophylaxis can also be established after doing a detailed clinical assessment and medical history. There may be other coexistent medical conditions in the patient, such as diabetes, hypertension, hepatitis, or any other treatment that can influence the choice of antiretroviral drugs. For example, if the patient already has or is known to have renal disease, then we know that we probably cannot be prescribing tenofovir to such patients. And so that already changes the first line ARV that we are going to give to the patient. So it is important to identify coexisting medical conditions by asking straightforward questions to the patient. Are you on treatment for any other condition? If so, what drugs are you taking? It is important, especially in children, especially in pregnant women, to determine the nutritional status and identify the gaps if there are any in nutritional status, and if there are any special nutritional needs that need to be addressed in these patients. Always elicit a past history of past medical illnesses, especially tuberculosis, especially STIs. TB is very important to know, because the presence of TB again changes your clinical stage. and it also puts the patient at risk for reactivation of tuberculosis. STIs or sexually transmitted infections again determine the risk of the patient, and so it is important specifically to ask about STIs. Many patients may not reveal the diagnosis or a past diagnosis of STIs unless you specifically question the patients about an STI. So it is very important to directly question patients about past or concurrent sexually transmitted infections and whether patient has received any treatment for any of these. Always try and find out whether or not the index patient has revealed or disclosed his or her serostatus to his family or partners. If a disclosure has been done, try and counsel them and offer index testing services for the spouse, for the partners, if there's only one partner. It is important. Also for sexual and injecting partners, do not forget injecting partners if there are any, especially among people who inject drugs. And also biological children, it is important to counsel the patient or the index patient to get his spouse and his or her children tested for HIV infection as the case may be. Always assess the need for psychological support. Assess who are the caregivers. Are there any identified caregivers? Is there any person who is the primary social support mechanism for the patient? Does the patient have a peer group or a support circle or a person or a group of friends who provide support, or is the family supportive or not? Presence of good social support determines adherence to antiretroviral treatment and patient outcomes in the long run. So it is good to have a good social support mechanism for each and every patient. However, if the patient has not having a good social support, then you can link the patient to certain peer groups who can provide adequate support. Psychological disorders, psychiatric disorders are again a very important aspect of treatment that are often neglected, and one needs to identify these if they are present, and maybe we need to refer the patient for appropriate services if needed. Next. Ask about where the HIV testing was done. Look at the report. Ask the patient to get the report. Always do a 4-symptom screening or a 4S screening for adults at each point of contact. For adults, ask for fever, cough, weight loss, and night sweats. For children, ask for fever, cough, poor weight gain or reported weight loss, and history of contact with a TB case. Ask for any persistent symptoms such as headache, poor concentration, seizures. They may indicate neurological involvement. Take a history of comorbid conditions like diabetes, hypertension, and others. Ask for a history of TB in the self or in the family, present or past. Ask about a prior exposure to ARVs in the past, history of STIs. Ask about HIV risk behavior. Does the patient have multiple sexual partners, multiple injecting partners? Does the patient belong to one of the key populations like people who inject drugs, commercial sex workers, MSM, um, transgenders? These are important high risk groups or key populations to identify because they are a highly vulnerable population and they need to be provided specific interventions regarding that. Always ask about present and prior substance abuse, and not only to drugs, it also includes alcohol and tobacco. We find that there is a lot of alcohol use among PLHIV who attend our clinics. We don't really emphasize too much on alcohol use, but we find that there is so much alcohol use and abuse among our patients. So we need to be aware of that. Always ask female patients, are they currently pregnant? It is very important to know that. Always ask whether or not the patient is using any form of contraception. It is important to know what is the size of the family, how many children a woman has had, does she desire to have any further children? So these are important questions that need to be kept in mind when we assess females. Ask about allergies to any medications. Ask about any other medications patient is getting. Ask about whether patient has received or is receiving vaccines. And determine the nutritional status regarding food intake, access to food, and how food is prepared, and what is the nutritional assessment of such patients. It is very important component of medical history. Next. So actually, this is a kind of a checklist that can be done for each and everything that I said. And you can ask for questions regarding each of them. But basically, remember, they involve testing. Where was the test done? Why was the patient tested? What is the test result documentation? If if the patient had been tested earlier, what was the test result? Positive, negative? When was it done? So it is an important part of assessment. Then, when you do a review of the clinical symptoms, these are the important symptoms that you need to ask each and every patient. Weight loss, whether he has noticed lymph nodes, night sweats, fever, headache, concentration inability, fever with chills or rigors, appetite loss, change in appetite, rash, sores or ulcers in the mouth, painful swallowing, chest pain, cough or shortness of breath, abdominal pain, nausea, vomiting, diarrhea, numbness or tingling in the hand and feet, muscular weakness. So if you look at this review of clinical symptoms basically involves asking questions relating to each and every organ system of the body to try and identify if there are multiple systems which are involved in the patient. And if so, you may need to do additional tests or additional examinations of a particular system or a particular diagnosis. Ask about HIV risks. Remember, a patient can have multiple risks. There can be a person who inject drugs, can also be a female sex worker. So you please remember, just identifying one risk is not enough. The patient may have multiple risks of acquisition and transmission of HIV, and it is very important to determine what is the self-assessed risk of the patient. So remember, the risk assessment is always self. The patient reports. You ask the patient for any risk, and the patient may or may not report to you, but it is important to always ask for risk. And these are all questions that you may ask in related to HIV related illnesses in the past. The patient may not know their names, the patient may not know diagnosis, but if the patient was ever admitted previously and does have a discharge card or have a hospital admission record, then maybe you can check for one of these illnesses. But always ask at least about TB in the present as well as in the past. Next. So, like I said, TB is very important. Always ask where was the TB, when was it diagnosed, did the patient take the ATT completely, what form of ATT was taken, what about the contacts, what about the family, and always do a porous screening at each visit. Again, you look for STIs and ask questions pertinent to the STIs. Take a general medical history for other comorbidities, like I said. Very important to ask a detailed ARV related history, ever received ARVs or ART, which form, what combination, how long did the patient take, why did the patient stop. All these questions are very important, especially if there has been a prior exposure to antiretroviral drugs. Substance abuse is very important. It is one of the key barriers to ART adherence and is one of the key reasons why patients are lost to follow-up. So we need to identify any ongoing substance abuse, and we need to address the substance abuse as early as possible. And of course, it is very important to ask about allergies to known allergies to drugs or any other substances. And if there is any allergy, especially to Septran or sulfa drugs, it is very important to write that and note that, because many times these patients get CPT prophylaxis, and the presence of sulfa allergies is a very important contraindication to prescribing CPT in these patients. Next, please. We go further asking about past medication use and the reason for the patient has been in use. Whether patient is on traditional or herbal drugs. Remember, many times, many patients take all forms of herbal, traditional drugs, pills, medications. And so we need to know whether the patient is taking any of these. We are not sure what the interactions of those are with the ARVs that we are going to prescribe, and to what extent the patient's belief in those systems are, because they can definitely impact the ART adherence of these patients. Ask whether the patient has had any menstrual irregularities, pelvic pain, pelvic discharge, and whether ever a pap smear has been taken ever, and if yes, what was the result and when was it taken. It is important to document that if it has been done. A psychosocial history relating to family history, disclosure of HIV status, spouse testing, social history, marital status, education, employment, occupation, financial support. These are very important key components of medical history that are going to strongly influence the patient's retention in care and the patient's overall treatment outcomes once you start the patient on antiretroviral treatment. Vaccination history, especially relating to BCG in the past, hepatitis A and B, and of course nowadays COVID vaccination is very important to determine whether the patient has been completely vaccinated, including the booster dosing for the COVID. All women, there should be a detailed history relating to pregnancies, past pregnancies, whether there have been any MTPs, how many children are there, have the children been tested, has any child passed away or died, what was the diagnosis in those children, were the patients ever exposed to ARVs during a pregnancy, which ARV and for how long that was given, is the patient on any contraception, when was the last menstrual period. These are very, very important key questions to ask all women in the reproductive age group so as to know these questions because they again can have a very significant impact on the patient. Always ask about the functional status of the patient. So there is something which is there in the functional status which is called W, A, and B. W means the patient is able to work, or a child is able to go to school or college, or a lady who is otherwise not employed is able to perform her usual housework. So such a person is categorized as working. Ambulatory is person is ambulatory, means able to walk around, perform his or her own small, simple chores, but is not able to perform any gainful employment or occupation. So such patient is categorized as ambulatory. And then, of course, the next is bedridden patient who is completely unable to take care of himself or herself and requires the constant support and supervision of a family or a friend. So you classify this as working, ambulatory, or bedridden. Someone is not able to see the screen. I don't know why. Maybe it has some technical problems. And if a patient is bedridden, you need to identify as to amount of day care that is needed, day-to-day care that is needed by that patient. And this is especially true in patients who are having neurological diseases, blindness, paraplegia, hemiplegia, dementias. So these patients require a lot of care. So it is very important. Now we come to the examination after history. So it is the same. The set of examination or the pattern of examination is the same as you would do for any other patient who is non-HIV or who is not HIV infected. But there are certain things you will specifically like to look for in these patients, and that is what we are going to stress a little bit here. So physical examination involves general physical examination and systemic examination, including examination of each and every system at the first assessment. So in general physical examination, you look at the patient, you see whether it's conscious, oriented, not oriented, sitting, lying, walking. What is the temperature, pulse, blood pressure, respiratory rate? These are the vital signs which you must examine. Look at the body weight, look at the height, calculate the BMI. This is especially true in pediatric population, but it is also very, very important to have a nutritional assessment parameters or anthropometric measurements in every adult at baseline. Look for pallor, ictus, cyanosis, clubbing. These are important physical signs that give us clues to an ongoing underlying illness. Always palpate for all lymph nodes. Patient may not have noticed any lymphadenopathy, but it is important for us to palpate for lymph nodes in all these patients because they could be the only site of active TB in the patient. So we must examine cervical, axillary, inguinal, all lymph nodes must be examined in great detail. If there is a lymphadenopathy, one needs to assess that in greater detail. Examine the mouth and oral cavity. When you're examining the mouth and oral cavities, specific, pay specific attention for any oral ulcers, any oral candida, any oral hairy leukoplakia, any other large ulcers or lesions that you can see, glossitis, cheilitis, angular stomatitis. These are important things that you will look for specifically in the mouth and oral cavity examination in PLHIV. Examine the skin Look for any nodules, look for molluscum, look for PPE, papular pruritic eruptions, look for any other skin lesions, nodularity. There could be diffuse fungal lesions, there could be nodular lesions because of many other diseases. Always ask and specifically look for STIs. Patient may not have revealed to you, but genital examination should be able to reveal evidence of any ulcers, any lesions on the glands. So you must examine these areas in detail. And systemic examination is guided by your history. If you feel that patient is having fever and cough and expectoration and breathlessness, you will do a more detailed respiratory examination. If a patient complains of diarrhea and you notice jaundice, then you will do a more detailed abdominal examination. So depending on what you are getting in the history on the basic examination, you will then perform a more detailed systemic examination of the respiratory, abdomen, cardiovascular, and neurological systems for a detailed assessment of the patient. Next. After a history and examination, you will be able to categorize the patients according to the WHO clinical staging. Remember, it is a clinical staging. There is no lab parameter which is included as part of the WHO clinical staging. Stage 1. Stage 1 means either the patient is completely asymptomatic and has nothing abnormal on examination, or the patient only has PGL, persistent generalized lymphadenopathy, which means painless enlarged lymph nodes more than 1 centimeter in size in 2 or more non-contiguous sites, excluding the inguinal, in the absence of any known cause, persisting for 3 months. So this is 1, 2, 3, more than 1 centimeters, 2 sites, 3 months, painless. It is called persistent generalized lymphadenopathy. The presence of either of these two will classify the patient into clinical stage 1. Next slide. Clinical stage 2, by the time the patient when the patient starts developing symptoms, whether they are minor or major, the patient then goes away from stage 1 and goes on to stage 2. Again, here I'm going to restrict myself to adults because there are certain differences between children and adults. Any adult who has moderate unexplained weight loss but less than 10% of the prior measured body weight, recurrent minor respiratory infections like sinusitis, tonsillitis, otitis media, pharyngitis, herpes zoster. Remember, herpes zoster is stage 2. Angular cheilitis, recurrent oral ulcerations, papular pruritic eruptions, fungal minor name changes, seborrheic dermatitis. All of them categorize the patients into WHO clinical stage 2 disease. Next. Beyond that, when there is more severe assessment, then the patient goes on to clinical stage 3. Unexplained severe weight loss. Remember that in stage 2, it was less than 10% of the presumed body weight or prior measured body weight. Here it is more than 10% weight loss. Unexplained chronic diarrhea for longer than a month. Unexplained persistent fever, again for longer than 1 or more months. Persistent oral candidiasis, oral hairy leukoplegia, pulmonary tuberculosis, very important. Any PLHIV who has pulmonary TB has WHO stage 3 infection. Severe bacterial infections such as pneumonias, empyema, pyomyositis, bone or joint infections like osteomyelitis, meningitis, bacteremia, all of them put an adult or an adolescent into clinical stage 3 disease. Next. Also included are unexplained anemia less than 8 grams, neutropenia less than 500, and chronic thrombocytopenia less than 50,000 cells per cubic millimeters, or acute necrotizing ulcerative gingivitis or periodontitis or stomatitis. Again, classify the patient as having stage 3 disease. Next. So stage 4 has all your named infections like HIV wasting syndrome, pneumocystis pneumonia, pneumocystis jirovecii pneumonia, recurrent severe bacterial pneumonia, Chronic herpes infections, orolabial or vaginal or genital of more than 1 month duration. Esophageal candidiasis. Remember, oral candidiasis was stage 3. Esophageal candidiasis is stage 4. Extrapulmonary TB. Very important. Pulmonary TB is stage 3. EPTB is stage 4, which means anybody with pleural effusion also will be classified as EPTB stage 4 disease. Next, there is more to this list. Kaposi sarcoma, cytomegalovirus infection, central nervous system toxoplasmosis, HIV encephalopathy, all forms of cryptococcosis, including cryptococcal meningitis, disseminated NTM infections, non-tubercular mycobacterial infections, PML, progressive multifocal leukoencephalopathy, chronic diarrheal diseases with cryptospora, with isospora. Next, disseminated fungal infections like histoplasma, coccidioidomycosis, malignancies like lymphomas, which could be cerebral lymphomas or B-cell non-Hodgkin lymphomas, recurrent septicemia, invasive cervical cancers, atypical disseminated leishmaniasis, HIV-associated nephropathy or cardiomyopathy. All these disorders and infections classify or categorize your patient into stage 4 disease. All right. So let us look at some questions. Quiz time. What do you think the patient is having in the clinical picture? And what is the clinical stage of the HIV infection? Is anybody chatting, writing any answers? I don't see any answers as of now. Okay, somebody has written stage 3. Why did you write stage 3? Somebody has written stage 2. Why stage 3? Why stage 2? What is the disease? What is the clinical picture? What can you see? This is, we don't know whether this is chronic herpes because we don't know the duration. This is herpes simplex. This is not herpes zoster. This is herpes simplex because this is perioral herpes labialis. It is just around the lips, herpes labialis. If it was more than 1 month, then it becomes stage 3. Otherwise, it is stage 2. So this is stage 2 disease. All right, let us go further. Next, please. This one, everybody. What is this? What is the OI and what is the stage? What is the OI? Anybody? Yes. So here we can see that the patient has different kind of vesicular lesions. These are happening on the skin. They are multi-dermatomal in distribution. So this is herpes zoster. That was herpes simplex. This is herpes zoster. Next slide, please. Yes. What is your diagnosis of the OI and what is the clinical stage? Anybody, can you see these lesions? Can you see these whitish lesions which are there everywhere on the inner surface of the lips? They are also there on the upper part of the gums. They are also there to some extent on the lower lip. Yes, absolutely correct. This is oral candidiasis. Since we don't know the detailed examination, from here what we can say, it is oral candidiasis. Oral candidiasis is stage 3. Oral candidiasis is stage 3, whereas esophageal candidiasis would be stage 4. Next, please. So this is a patient where you can see that there is oral candidiasis, which is very florid, but you can also see that the fauces are involved here. If you see the fauces here, and also the palate, and also probably the uvula and beyond. So this is oropharyngeal or oroesophageal candidiasis, which then puts the patient onto clinical stage 4 disease. Next, please. Anybody? What do you think is the abnormality that you can see here? What is the abnormality that can be seen here? Yes. So as somebody rightly pointed out, you can see that there is a whole group of lymph nodes here. Cervical lymph nodes, which is large. So there is large lymphadenopathy, and they seem to be a conglomerate matted kind of a mass here. Even if this is TB, it becomes stage 4. Of course, because it is EPTB. Of course, if this turns out to be something else other than TB, for example, if it is a lymphoma, then also it becomes stage 4. So this patient has clinical stage 4 disease. Next slide. So now when you examine these patients, it is important not only to determine the clinical stage, but also to determine two other things. One is to diagnose or identify those PLHIV who have serious illness. And the other is to diagnose PLHIV who have advanced HIV disease. So what are the signs of serious illness? If any PLHIV at presentation has any one of the following signs, then one must refer these patients for evaluation by a medical specialist and probable admission into a hospital. This cannot be managed from the ART center itself. So any PLHIV who has temperature more than 39 degrees Celsius associated with headache, anybody with a respiratory rate more than or equal to 30 per minute, anybody with a heart rate of more than equal to 120 beats per minute, any PLHIV whose SpO2 on a pulse oximetry is less than 90%, any PLHIV with altered mental status like confusion, abnormal behavior, reduced level of consciousness, anybody with any other neurological problems like persistent severe headache, seizures, paralysis, difficulty in talking, rapid deterioration of vision, or if any PLHIV is unable to walk unaided. Many times we find that PLHIV are lifted and brought by their attendants because they are not able to walk. All such PLHIV are labeled as those with serious illness. All such PLHIV have to be assessed at first visit by a specialist, and then there needs to be a formulation of a plan for management of such severely ill PLHIV. Such PLHIV are likely to have very high mortality, and so it is very important that they be assessed promptly and appropriate steps taken for the management of these patients. Next slide. The next thing that we must identify among PLHIV is those who have advanced HIV disease. For all adults and adolescents and children older than 5 years, advanced HIV disease is identified as any PLHIV who has either a CD4 cell count of less than 200 or has WHO 3 or 4 event. So whenever a patient is categorized at WHO 3 or 4 stage, the patient gets categorized as advanced HIV disease, irrespective of the CD4 count. And of course, if you have a CD4 count, anybody with a CD4 count of less than 200 is classified as advanced HIV disease. Any child less than 5 years of age is automatically classified as advanced HIV disease. Next, please. One must perform a nutritional assessment in all these patients because undernutrition labeled as less than 18.5 kilogram per meter square BMI is a recognized independent risk factor for mortality in PLHIV. So you must perform anthropometric measurements like body weight, body height, and BMI. Look for edema. The presence of edema may indicate hypoalbuminemia or hypoproteinemia, and again, it is a very important marker of malnutrition and mortality. And take a dietary and food history, and it is important to identify what is the dietary intake of these patients and whether we need to advise any kind of dietary interventions for such patients. Next. Then there are certain baseline investigations which are essential and are mandatory for all patients who are registering in HIV care at any ART center. They include a hemogram or a complete blood count, a urine examination for routine and microscopic examination, fasting blood sugar, a blood urea and serum creatinine, serum bilirubin and ALT, also called SGPT, BDRL, CD4 count, and a chest X-ray. These investigations are essential for all patients at initial assessment. Next. You can do additional tests depending upon what you have identified on your initial assessment and initial evaluation. They could include tests for diagnosing OIs. For example, if you think a patient is having recurrent abdominal pain and there is hepatosplenomegaly and you think that there could be abdominal TB, then you could ask for an ultrasound abdomen. So it depends. Those investigations are directed depending upon what your initial assessment was. It is ideal to identify hepatitis B and C co-infection in all these patients. A lipid profile, if available, is to be done. In case you are suspecting leishmaniasis, an RK39 strip may be done for these patients. If you think a patient could be pregnant, then you must perform a pregnancy test. For men having sex with men, anal pap smear, and for other women, a cervical pap smear may be done for cancer screening. But remember, none of these tests are mandatory prior to starting ART. Remember that they need to be done, they are essential to be done. But non-availability or non-feasibility of any of these tests should not delay initiation of ART. And I'm talking especially in relation to ultrasound because I find that we get very long dates for ultrasound from our radiology departments. It may take months to get a date for an ultrasound abdomen. We cannot, just on the basis or just for the lack of an ultrasound, not start ART. So please remember, if you think they are very important, kindly expedite those investigations. Otherwise, they should not be a barrier for you for timely initiation of antiretroviral treatment in these patients. Next. So on the first day, you have done all these things like I have said. After this, you do a readiness assessment or preparedness counseling. You have done some baseline assessments have been sent. You can initiate CPT if the patient is eligible based on your CD4 count if you have it on your first visit. And if the patient is already well prepared, then you can actually start the patient on ART at first visit itself. Because now anyway, all patients are eligible, all PLHIV are eligible to receive ART. And concurrently, you can send the samples for CD4 and other counts. Next. You can call the patient within 3 to 15 days after initiating ART, especially if you want to review the test results which you don't have at baseline. Especially if they are not normal, patients can be called back within 2 weeks of ART initiation, and the call has to be made by the counselor and just inquire about the patient's well-being. And in each subsequent follow-up visit, you will ask, again, take a history, do a symptom checklist, do a repeat clinical examination. At each visit, a 4S screening has to be done. Look for any side effects of drugs of the ART that you have prescribed. There is a follow-up monitoring of ART testing or follow-up of lab testing that is done, and that needs to be done at each subsequent visit depending upon what ART regimen patient is getting. We counsel the patient at each visit, and we also assess ART adherence and provide continual adherence support at each and every visit. Next. All right, so that is my last slide where I have talked to you about in detail about patient assessment and initial follow-up, initial assessment of patients who present to the ART center.
Thank you so much, ma'am. Ma'am, do you want me to take the questions in the chat box? And yes. Okay, I'll take it in the chat box and then I'll email it to you.
Okay.
Right. Thank you so much, ma'am. Participants are requested to please post their questions in the chat box. In case you have any queries, please post them in the chat box. Ma'am has a urgent